Bismillahirrahmanirrahim. First of all, I would like to thank the organizers for giving me this opportunity. And secondly, I think it has been an excellent conference, Tipu, Sohail. Very well arranged. The previous session was very, very informative. And I think it was all the speakers needed appreciation for that. What I'm going to talk to you about today is aortic stenosis, and the title given to me was uh, State of the Art. That takes about 20 to 25 minutes. So I'll just concentrate on some of the diagnostic intricacies here. Now, when we teach, actually we learn ourselves, and that is what I found when I was going through all the papers to try to formulate my presentation here. Why are we talking about aortic stenosis? The reason is that it is the most frequent valve disorder. Incidence increases with age, and there is no proven medical therapy which can actually delay progression, and valve replacement is the only definitive treatment that is available to us. What really happens is that you have aortic stenosis, which increases the afterload, and as a result of that, you are going to have an effect on the left ventricle, left atrial, pulmonary vasculature, right ventricle, and from here you will get the symptoms and the prognosis in these patients. The classic symptom that we have are exertional dyspnea, angina. The classic symptom that we have are exertional dyspnea. We have angina, syncope, and if you remember from your college days, there is a crescendo decrescendo murmur with a delayed second heart sound, and in advanced disease, you will have the soft second heart sound. You confirm the severity and the phenotype with echocardiography. We have a lot of other modalities available to us. There are emerging biomarkers and therapies, broader indications for TAVR, which means that now, even in the younger patients, you can actually submit them to TAVI or TAVR. And a midterm 5-year low risk randomized evidence between TAVR and surgery remain comparable for death disabling stroke. It's not a passive wear and tear. It is not something which comes because of wear and tear to our bodies. In fact, it is an active fibrocalcific process which involves inflammatory and osteogenic signaling. And it all undergoes all these processes. And ultimately, there's LV remodeling, symptoms, heart failure, and adverse outcome. This is what you actually get on echo, where you have a continuous wave Doppler giving you the gradient across it and the different parameters that you have for severity, mild, moderate, and severe. But and in there you have the mean gradient, the V maximum, and the AVA, which you calculate in these patients. The hallmark is actually the LV aortic systolic pressure gradient in these patients with aortic stenosis. Previously, when we started echocardiography, it was basically only the gradient which was there. But that actually ultimately resulted in many of the misdiagnoses or perhaps the fallacies which I'll show to you in my subsequent slides. The cardiac damage actually accumulates over time, and we see this happening in our patients with aortic stenosis, which affects the left atrium, it affects the left ventricle, it affects the pulmonary vasculature, it affects the right ventricle, and that is why we need to actually, even in asymptomatic patients, intervene early in patients who have moderate aortic stenosis. Now, This is a very famous curve, and you must have seen it many times. There is a long asymptomatic stage, and once the symptoms start, there is a sudden decrease in the life expectancy with heart failure, syncope, and angina. Without valve replacement, there's an increased mortality and morbidity. With aortic valve replacement, there is an improvement, and the mortality and morbidity reduces in these individuals. So the onset of symptoms is extremely important. Then, if we look at the burden of the heart valve disease, we see that the aortic valve disease is increasing as the age advances. This is what we have to keep in mind. When we are diagnosing aortic stenosis, it is with 2D echo and 3D echo, the color Doppler, continuous wave Doppler, and pulse wave Doppler. Then we have the strain imaging we have heard about in the morning, and I'll show you some of the pictures. And now we have the artificial intelligence. It's extremely important to take the images from all the windows, especially when you need the maximum gradient. It is from the right parasternal view that you have to actually get the maximum gradient. You need to be aligned properly to the flow. That is why you will be needing all the windows, including subcostal and suprasternal. You need the alignment to be straight with the blood flow which is you are receiving when you're doing the Doppler. And also important it is to be able to measure the left ventricular outflow tract properly. And for there, I think it is important that you slightly tilt the transducer where the right coronary cusp becomes more prominent and the non-coronary cusp disappears. You will find that you are able to get a better LVOT leading edge to leading edge and make a slight adjustment in the sense that you can increase it by 1 millimeter, probably making for the elliptical LV, left ventricular outflow tract. This is the continuity equation that you will, where you will get the aortic valve area by the LVOT diameter, the LVOTI DVI, and the aortic valve DVI. So what happens when the peak gradient is less than 64 and the mean gradient is less than 40? In such a situation, can we have a severe aortic stenosis with not a very high gradient? The common answer, yes, in low ejection fractions. You have low flow, you have a low ejection fraction, but the gradient is low. The aortic valve area is less than 1 centimeter square. There is a discordance between the two. Severe aortic stenosis with low gradient, and there is also a normal ejection fraction in these patients sometimes. So what you need to do is to have all these parameters, always plug in the height and the weight into your patient's data, and then calculate with the continuity equation, you will calculate the aortic valve area, and then, sorry, you need to calculate the stroke volume, the ejection fraction, and the aortic valve aortic flow rate. I'm going a little fast because of Shahbaz's server here. Low gradient, severe aortic stenosis. You have low flow, low gradient aortic stenosis. Very important. 30% of the cases with aortic stenosis has this entity, and you need to actually identify them. Then you have paradoxical low flow, low gradient aortic stenosis, and with a normal ejection fraction. And you have a normal flow, low gradient aortic stenosis with a normal left ventricular ejection fraction. So, in this situation, what do? You actually then uh, what next? You actually add dobutamine echocardiography, and this is not like the dobutamine stress echo that we heard in the morning. It is you go up till about 20 micrograms, and then you are able to actually open up the aortic valve and the flow increases. If the in such a situation, you might be able to increase the gradient in these individuals, and that way you will be able to identify the low flow, low gradient severe aortic stenosis, which actually is in 30% of the cases. If it's a high flow, if you have a aortic valve area less than 1 centimeter square and the gradient more than 40, then you don't need to do anything else, because that there you are completely sure that it is a severe aortic stenosis, and you send the patient for surgery or for TAVR in these patients. Here, for example, in this continuous wave Doppler, you find that there is a reduction. The gradient is not very high, and you calculate the left ventricular outflow diameter, and the ejection fraction is low in this patient. As a result, the aortic valve area is 0.72 centimeters, and you find that there's a discordance. The gradient is low, but the aortic valve area is less than 1 centimeter. After dobutamine infusion, what happens is that there is an increase in the AV mean millimeters of mercury gradient, and it is 44. You are sure now that the patient has severe aortic valve stenosis. So this is what you need to do. And ultimately, in this patient, the gradient also increased with dobutamine infusion. So after you have been able to identify it, then you plan for surgery or TAVR. So with the aortic valve area less than 1 centimeter square, 1 centimeter low gradient, you put them through a dobutamine stress echo. The contractile reserve is positive. This is true stenosis. The patient goes for surgery. If the contractile reserve is if the gradient does not increase, it still is less than 40. The valve area increases to 1 centimeter. This patient goes through for medical treatment. And in those cases where there's no contractile reserve, then actually the adjudicator is the aortic valve calcium score. I think I'll just go through quickly with this and come to my last couple of slides, so that the as regards the aortic valve calcification, it is you will see that there is a very good correlation between the aortic valve area and the aortic valve calcification. This you can actually use as an indicator in your patients. So the calcification score for women, it is 1200, and for men it is 2000. I'll come to the last slides. When you actually have an aortic stenosis gradient and the aortic valve area which is concordant, you are happy. When there is discordance, then actually you adopt the other measures like dobutamine stress echo and the aortic valve calcification. So you can add strain imaging to it if you have a normal ejection fraction in a patient with aortic stenosis, and you have the global longitudinal strain which has been reduced. You know that this patient needs to undergo surgery or TAVI, and it normally reduces at the basis. This is how there's a decrease in the global longitudinal strain as the left ventricular ejection fraction falls. These are the different flow gradient patterns that you have. So the take-home message is that don't rely on single echo number. Integrate symptoms, gradients, aortic valve area, flow, GLS, BNP, and CT, aortic valve calcification when discordant. If low flow, low gradient, or normal flow, low gradient suspected, use the vitamin echo. Refer symptomatic severe aortic stenosis promptly to the heart team, and watch for subclinical LV dysfunction In asymptomatic severe AS, this increase the threshold to consider earlier intervention. Thank you very much.